We have got one over here on the left.
Hi, I'm Kirsten. I'm here again, everybody. I would like you guys to give us just your overview, not so much about AEA, 2AG, or the phytocannabinoids, but about upregulation of CB1, CB2, and possibly even TRPV-1. So if there's a method or an analysis of those receptors, or maybe people just don't upregulate, there might be something that you guys have to say about that. Thank you.
Well, I just briefly touched on a study from a couple months ago that was using PET scans to look at CB1 receptor densities in people that had tolerance to THC-based cannabis, and they found that after 2 days of abstinence, those receptors came back to normal level. So we know that CB1 agonists can downregulate the CB1 receptors, and we know that taking a break from those agonists can upregulate it. There's probably other ways to upregulate it as well, which are covered in Dr. McPartland's paper that Ethan just mentioned.
Right. I'd add something else. I think that heretofore there's been too much concentration on THC. If you ask me what drug would upregulate the system over time, it would be cannabidiol. And when used chronically, it does seem to increase the gain of the system and help with so many aspects of this. Beyond that, and again, from John's paper, you have aerobic activity, seems to upregulate the system. There's good evidence that the runner's high is an endocannabinoid mechanism rather than related to endogenous opioids. And then finally, the prebiotic probiotics may figure into this in a big way. They seem to produce many of the same benefits on illnesses that cannabidiol will, for example.
Thank you very much.
I was wondering if I use cannabis topically for pain, and I was wondering if you have ever administered it or had somebody use it for skin cancer.
For what?
Skin cancer.
Yeah, there have been many attestations on the web of curing or eliminating skin lesions, including cancers with cannabinoids. This really, what's amusing to me is that this isn't new. This has been reported for hundreds of years in other cultures. It's just that we forget history, and because they didn't have double-blind controlled studies then, nobody pays any attention to them currently. But yeah, you know, it's clear that many of the phytocannabinoids, not just THC and CBD, have this ability to kill cancer cells in high concentrations while being preservative for normal cells. So a great deal more work in a palatable form. In other words, the double-blind controlled studies need to be done so that the rest of the medical community will accept these results.
Hi, Jeff Block, University of Miami. A question probably for Dr. Sulak. The 2-day abstinence, considering perhaps a longer time for chronic downregulated patients, and can you share with us how you rate the 2 days, and if in fact you may miss a full healthy retrieval of a naive system to work from?
Sure. I don't think that any program is going to be the optimal program for everyone, but based on the work I was doing about 5 years ago when I was asking people to take different lengths of abstinent breaks, it seemed to me that most people did really well with 2 days. In the 6-day program that I developed, the 3 days after the 2 days of abstinence involve very low doses of THC. So it's almost abstinent, but we're just very gradually reintroducing it. And I'm not sure that that's the best method. It's just the best one that I've found, and it seems to work for most people.
Well, any comments on starting off with a full complement a la the NIDA study after 4 weeks of abstinence?
I'm sorry, could you repeat the question?
Any benefit to starting off with a full complement of receptors a la what showed
after a longer
4 full
abstinence
weeks?
break. I'm not sure. I think some patients, they might need longer than 2 days, but I doubt many would need a full month.
Hi, this is Guillermo Moreno from the University of California, Irvine. I first described the peripheral restricted FAAH inhibitor, URB937, which has been proved to be effective in a model of migraine and also be an effective painkiller. And that got me interested on the possibility of activating peripheral CB1 receptors as opposed to both central and peripheral. The research on THCA that Dr. Sulek has presented got me thinking after an interaction with a patient with breast cancer, if you believe that the presence of the carboxylic acid in THCA might prevent it for accessing the brain. That would be one of my hypotheses. And then the fact that it is effective is something that we were discussing with Dr. Costin too. Will it be possible in a case of epilepsy that a peripheral CB1 agonist will help with the seizure, but not with the central spike, if that makes sense? You know, able to control the motor component of the seizure without controlling the central. If you think something like that will be possible. Thanks.
Boy, I don't know.
Well, those are some interesting ideas. I think that from my experience, pretty clearly, THCA does penetrate the central nervous system, based on some of those studies that I presented. And I think that the peripheral activity of THC as an antispasmodic wouldn't be potent enough to really, it might reduce the intensity, but I doubt that it would reduce the observable effects of the seizure altogether.
I'd like also to add to that, I'm not sure why you just want to stop the motor activity of the seizures, because if the brain activity is still going on, that can still continue to cause damage.
Right. We were questioning whether or not we were seeing just non-convulsive seizures when we give THCA. Was it calming down the motor manifestation? But possibly, if we hook somebody up to an EEG, we'd still be seeing some seizure activity on brain waves.
Gotcha. And that would be an interesting question to look at. And that's one of the things I do with all my CBD patients that I have on epilepsy. I monitor their EEGs very closely and very frequently. No, in Florida, where I was practicing, unfortunately, we weren't allowed to use THCA, so I didn't have any experience with that.
I'm not sure if Dr. Gaetanis is still here, but he has looked at EEGs of some of the THCA patients. Maybe.
In the back, but it's mixed. I've had some patients where there's no change in spike weight discharges in terms of frequency, but and others where I've seen a pretty dramatic improvement in spike weight frequency. With the seizure question, though, the question of like a non-convulsive status or non-convulsive seizure, we did have one of our patients who was getting THC to abort seizures. We actually had hooked up on EEG at that time, and it truly aborted the seizure. There wasn't an electric seizure with absence of convulsions. And that's what we see that clinically, because the patients who've used THC to abort seizures are alert after. So it's pretty, that's the most dramatic part, is when they get diazepam or Valium to break the seizure. It usually means rectal diazepam. The patient's out of it for like 5 or 6 hours. If they get THC to abort a seizure, they're alert within 10 to 20 minutes. They're back to themselves, pretty close to it. A little giggly, but really good. So that's how you know the seizure's ended. I think there's no doubt that it's truly stopping the seizure.
Yes.
Hi, I'm Pat Fry. I'm a private practitioner. My question is regarding patients who are using cannabis for its anti-tumor or anti-prolific activity. Is it a lifelong commitment to cannabis therapy, or is there any, I know there's no protocol for anything, but what is the approach for patients who are able to go into remission? And then the second part of my question is regarding pregnant and lactating women. I'd like to hear the panel's thoughts on cannabis use in that patient population.
Well, I can answer the question on the anti-tumor. It's a very good question, because it's something that patients come in and ask, is how long am I going to have to take this? It's expensive. Sometimes the high doses of THC disrupts your functional ability. And so we don't know. there's no clinical trials. We don't know if somebody, there's anecdotal reports of people taking high-dose cannabis oil for 3 months. They report that they're cancer-free, and then they go about their business, and they're not taking high dose anymore, but one presumes that they might be taking some low-dose cannabis for other symptoms, and it's possible that that might be keeping them at a level of cancer freedom. Many of my patients who have very advanced cancers who get good results are terrified to go off cannabis oil. And so many of them will reduce the dose once they have some success, usually after 6 months, sometimes a year, if they achieve cancer-free or in remission. And the reality is nobody really knows how long to stay on it. It would be very interesting to start looking at these patients to see if, can you stop right after, or is it 5 years like they talk about in the conventional treatment? It's hard to know.
I have a few colleagues that have treated patients with cancer, including on medical marijuana for a year or more so, and they've been taken off of it and the cancers have recurred.
Interesting. Okay, we'll go with Fred Vogelstein over there. Or sorry, Hans.
You're just not going to let that go, are you? Hey, it's Fred Vogelstein at Wired. For Dr. Goldstein or any of you guys, assuming that patients are taking, say, 25-to-1 CBD oil, at what dosages can you administer before you start to see THC effects on some of the kids? So, for example, like at 25 to 1, for example, 250 milligrams a day would be 10 milligrams of THC.
Right.
Do patients tend to see any kind of THC effects, or do the CBD effects tend to cancel those out? How does that work? What's been your experience?
Well, I can talk to my experience, and then I'll let the other panelists talk to theirs. I do find that children, and there's one report in the literature that says that children may have immature cannabinoid receptors, so they may not respond. I do find children tolerate THC much better than adults. Many of them do. I have not found, and people ask me, how do you know a child's not high, right? And many parents can tell. We had a problem or I should say 7 patients contact me, not this past summer, the summer before, right around the same time. There was a product parents were sharing information on the internet about a particular 25-to-1 ratio CBD made from AC/DC, and the company had shipped out just a new batch to a handful of my patients, and on a Friday I got a call from a mom who said, okay, this batch is different, my kid's acting weird. And I wasn't sure what to make of it, and then the next day I got 2 phone calls, we just got a new batch, people who did not know each other. My kid's on the floor giggling, and one parent says, my kid's hasn't gotten out of the refrigerator. I mean, these were clear cut, and then 4 out of the 7 parents that reported this to me actually took the oil themselves and reported that they were, that had major psychoactivity. And so it was clear cut that these people were able to recognize psychoactivity. I do not hear that from my families that are using the 25-to-1, even with very high doses, 200, 300, sometimes 450 milligrams. That being said, I do find that many patients who are able to be verbal about their experience find that if you start at a high dose, they have some difficulty. So we start at a lower dose and we titrate up. I do that anyway, but for some families who came to me without me starting them, they started earlier, prior to my advice, they said, oh, we were told to start at 300 milligrams a day, and the kids kind of wiped out from it. So there may be some tolerance issue there that you start low and you are able to build it up over time.
Yeah, I'd echo that. You always want to start low and use the dose that's effective. With these high CBD, low THC. I like, my rule of thumb currently is to try not to exceed a total of 15 milligrams of THC a day after titrating upwards. And generally, well, particularly for adults, it's very unlikely someone's going to get into trouble with that approach. But even with these broad ratios, THC tends to overwhelm the effects of everything else if given the chance. And so titration from a slow start is really necessary.
Yeah, I have a question. Have any of you noticed a circadian rhythm to endocannabinoid activity, either with respect to time of day of dosing or increased pathology in shift workers or people with different sleep disturbances?
Well, I couldn't relate to that, but yeah, there's a lot of evidence to show there is a circadian rhythm to levels, and yeah, that literature exists.
Has there been any experience in time of day of dosing is more effective?
Well, the thing to keep in mind is these don't last 24 hours.
Okay.
Generally speaking, depending on the preparation and the mode of administration, most people are going to need to administer a cannabinoid drug 2 or 3 times a day. If they're inhaling, it probably is a lot more. But for chronic illnesses, there should be an emphasis on some kind of either oral mucosal or GI administration.
And do you see more pathology with deficiencies in shift workers or anybody who's...
I couldn't say for sure. It's worth study.
All right, thank you.
Get a grant.
This one's for Dr. Selleck here. You'll have to excuse me, the past few days have been a little bit of a whirlwind and the slides have gotten a little blurry already. There was one slide that you had up where you were talking about the up and down regulation of cannabinoid receptors in a 48-hour cessation from THC would then upregulate the cannabinoid receptors again. But then in the same slide, there was one showing that THC actually causes the upregulation of CB1. Is that dose dependent as well? Did you notice, or was that, or how does that work quite?
So I think it's pretty well established that enough THC or any CB1 agonist will downregulate the receptors. They're internalized. And there's just a little bit of evidence that a low dose or a single dose of THC can upregulate the expression of the receptors and also the affinity of the receptors.
Okay. Thank you.
Yes, this question is for Dr. Goldstein. Would you please comment on your experience with ADHD? And
I'm sorry, with what?
Your experience with ADHD and any ratios that you use on your patients?
Well, I always start with it's personalized, so different people can have the same diagnosis and respond differently to different ratios. I have patients using 27 to 1, 25 to 1, all the way down to 1 to 1. I do find that my adult patients with ADD or ADHD, when I very first started practicing, it was mostly people who were smoking or vaporizing THC, and they found very good results. And many of them, there's 2 kinds of patients that I see. Some that get enhancement of activity that like we're looking for if somebody gets Ritalin or Adderall, but without the side effects. And then I have another like subset of population who do find good results with the stimulant medications, but they find that some of the side effects are intolerable, including, loss of appetite and poor sleep. So they're using cannabis in the evening to counter out the effects of a medication that actually does work functionally for them, but at nighttime they are feeling the side effects. In my pediatric population, I am starting to see a lot of patients coming in because parents are very concerned about putting their children on these medications. I always start with pediatric patients with a high ratio CBD to low THC. Sometimes there's other comorbidity, epilepsy, autism sometimes exists, OCD sometimes that I'm seeing, and I just find that I always start at the high CBD, low THC, so like 27 to 1, 25 to 1, sometimes 21, depends on what the parents can find and get. And then I slowly will, depending on results, checking in frequently every couple of weeks, maybe titrate in a little THC to see what the effects are. I have a little boy right now that I'm taking care of that came to see me with epilepsy. He at the time was 4. He's been my patient now for 2 years. And he was having terrible rage with Keppra. It was impossible. They couldn't go anywhere or do anything. The family came in tears to me. We started him on CBD oil, and he responded beautifully. But what's interesting is that his ADHD and autism kind of persisted. No rage anymore, but he was really kind of a very difficult child. He couldn't be in a preschool. He wasn't really learning and had no focus. And we started very low dose THC added in as a separate for more treatment of that. And it turns out he's on a 1-to-1 ratio. He takes 50 milligrams of CBD 3 times a day for seizures, and he takes 50 milligrams in the morning of THC, which is a very large dose, and is actually in a classroom that's considered mild. And his focus, he's learning to read and write, and as the mom says, I feel bad giving him this, but he's not high. You know, he's going off to school and I'm getting good reports, and nobody knows he's on THC because she's worried about being reported. But meanwhile, the child's having major success. And so it really does depend on individual, but again, starting low and tiptoeing up on dosing and just really going by how the patient responds is really the way to go with cannabis.
And I just wanted to add, it's not a direct answer to the question, but because this conference has focused a lot on CBD, and especially in the treatment of children, I have found clinically that THC is a very safe and effective medicine for children with self-injurious behavior, violent behavior, chronic pain, with seizures, with many different conditions. THC seems to have a better side effect profile in children than it does with adults. And for some of these really sick kids, it's something that should not be ignored. It might even be a first-line treatment option because of better efficacy, faster at lower doses, better cost effectiveness than CBD.
Mm-hmm. So I think we've got time for one more 30-second question.
To the whole panel. 2 questions. One about the use, the efficacy, and bioavailability from nanoparticle cannabis, full spectrum, not just CBD. And the second question is, what other kind of chemical can be used to expedite bioavailability outside of nanotechnology?
I'll just address the second part. As we heard alluded to this morning, cannabinoids get in best with a lipid carrier. So you'll see a lot of preparations in sesame oil or coconut oil or ghee is a really good one. Additionally, absorption is aided by taking with food as opposed to a lot of other medicines, particularly herbal agents. But that would be the advice there.
All right, if we can thank the panelists here. This has been very enlightening and a productive discussion.